This is a 61-year-old smoker who presented with throat pain. On the post-contrast CT scan, axial scans, we start from the brain and the nasopharyngeal structures and we continue downward, and everything looks pretty well okay until we get to the tongue base. At this point we're at the base of the tongue level on the right side, and we immediately see a mass which is exophytic in nature and is starting to encroach on the airway. This tongue mass we're going to follow inferiorly into the vallecula. The vallecula is the airspace in front of the epiglottis, and you can see it well on the left side. However, on the right side the mass is encroaching on the vallecula. The vallecula is outlined also by the median glossoepiglottic fold seen here. At the same time that we're evaluating the primary tumor, we also see laterally the enlarged and necrotic lymph nodes, which are within the upper jugular chain. When these jugular lymph nodes are adjacent to and not wholly behind the jugular vein, we call them level 2A lymph nodes when they are above the hyoid bone. If we continue to see lymph nodes that are below the level of the hyoid bone, seen here, we then call the lymph nodes level 3 lymph nodes. If the lymph nodes are posterior to the jugular vein and have a fat plane between the jugular vein and the lymph node, those would be our level 2B lymph nodes when we're above the hyoid level. In this case, because of the large size of the mass, we're going to have to measure it in order to understand the T-staging. T-staging of oropharyngeal cancer is based on the size of the mass, with T1 less than 2 centimeters, T2 2 to 4 centimeters, T3 greater than 4 centimeters. So we would measure this in both the axial transverse plane as well as the AP plane. So the next part of the staging is going to be the end staging, which is the lymph node chains. And with lymph nodes, we have to measure them and see whether they're less than 3 centimeters, they're 3 to 6 centimeters, or they're greater than 6 centimeters. In this case, we have lymph nodes that are less than 3 centimeters, but there are multiple ipsilateral lymph nodes that are less than 3 centimeters. However, looking more carefully, we note that there is an additional necrotic lymph node on the left side, making this a contralateral lymph node with necrosis in the level 2A chain. Therefore, the nodal staging is going to be based on bilateral lymph nodes, and that would make it an N2C level staging of the tumor. For the extent of the tumor into the preepiglottic fat region, we look at the sagittal scan. On this sagittal scan, we can see that this base of tongue cancer grows into the vallecula and flips the epiglottis posteriorly. However, the preepiglottic fat is clear, and this is important because if there is preepiglottic fat invasion, it will upstage the lesion from a T2 2 to 4 centimeter mass into the T4A category with preepiglottic fat invasion. So in summary, we have a patient who has a base of tongue cancer which extends into the vallecula. It measures approximately 3 centimeters and therefore is a T2 cancer. And the patient has bilateral necrotic lymphadenopathy, multiple lymph nodes, and therefore represents N2C disease.